So once again, welcome to the Branford Forum. It's a great pleasure to welcome Professor Saad Omer, who is director of the Yale Institute for Global Health. And he will be speaking to us today about COVID vaccines, both about the vaccines themselves and about the social acceptance of them. Professor Omer, thank you for joining us.
My pleasure. So let me share my slide and let me see. So I'll be talking about the so-called promise of COVID-19 vaccines because the full potential is in the process of being realized. It hasn't so far. But they are the most promising intervention to end the impact of this pandemic. I have structured the presentation in a way that I have, usually when I present these kinds of things, there are several questions. So I have kept some time for questions, etc. And would be happy to go into some depth on any of the topics that you would like to discuss around vaccines. So first of all, this is the current situation. We have a substantial burden of this pandemic. It was almost a year ago when WHO started calling this, the World Health Organization started calling this outbreak a pandemic. Actually, it was less of a distinction technically than people make it out to be. The big announcement that WHO made was January 30th, 2020, where they called it, that's the technical term for an outbreak that goes beyond in its implication an individual country. It's called FEAC, or Public Health Emergency of International Concern. That came in late January. So they warned us, and other countries warned us in terms of gearing up for this response. But nevertheless, we've had this tragic spread of this outbreak as a world overall, and as a country. We haven't been able to control this outbreak. We have been able to mitigate its impact, and we have had periodic control, like better control periodically than before, but compared to other periods, but we haven't been able to fully control this outbreak. Recently, we had a decline. So we had the first wave in this country. We felt it in Connecticut as well in April, starting in March, mid-March, and peaked in mid-April. And there was a slow decline in terms of the number of cases. Then we had a summer increase. Connecticut avoided the big brunt of the summer wave that was more widespread overall. And then we had the huge tsunami of a wave starting in November, so November, December, January, and then we've had a pretty drastic decline recently. Now I'll go into the details of what, or I can go into the details of what is dictating this decline, but I think, briefly, it is both behavior, it is the change, you get these waves in the winter season, in the respiratory season, and then people, it was after Thanksgiving, but people didn't really pay attention to travel advisories, etc. There's all of these reasons why it has come down. But on the other hand, vaccines have only in past few weeks have started showing their impact. So it is not the national trends. There's local trends that are driven by the impact of vaccines, but the national trends are beyond that. But we will see an increasing contribution of vaccines in decreasing the rates of both cases, but more importantly, deaths. So in the US, there is heterogeneity beyond the population distribution, even otherwise as well. There is heterogeneity in terms of mortality that's dictated by the effectiveness of response, but also how early some populations got infected, and sorry, and the age structure. We know this virus disproportionately impacts individuals and and groups that are older, and the risk is substantially higher in those who are older Americans, especially those living in long-term care facilities. The other part is that we know that even adjusting for age, communities of color have been disproportionately impacted by this virus. The mortality is twice as high in Latinx and Black communities in this country, and Native American communities as well. So the deaths followed the trajectory, but they lagged by a few weeks in terms of their rise and fall. And similarly, in the current wave, these deaths are coming down fairly fast, etc. I think we will see in the coming weeks a decoupling of deaths and cases, because we are, and I'll go into the details a few details a little bit later. They're coming down, they will come down faster than cases, because we are prioritizing overall the highest risk groups, with some variations on how what are classified as highest risk groups for mortality. So the deaths may come down faster or maybe more durable, and then the reduction in mortality is more durable than reduction in deaths. But having said that, we are still having, every day there are 1,500 Americans dying from this virus. And so to keep in mind, it's lower and going down, but we are not out of the woods. So it has been a bit of a miracle that within a year, in fact, less than a year, we've had throughout the world, multiple viable candidates of vaccines. And it is good that it's not just the US, but around the world, there have been vaccine successes with some failures as well, and which was totally expected. Not everything that you try out works in science, but we do have a pretty robust set of vaccines around the world. I will focus in more detail the vaccines that are authorized in the US. But just to, one of the early questions come up that, have we cut any corners? Has the process been deficient in any way compared to the normal vaccine development and approval process? But the short answer is no. But it has been faster, and it's a natural, it's a reasonable question to ask. Well, if we haven't cut any corners, then how come this has been faster than other vaccines? The idea is that you usually have phase 1, 2, 3 trials, where you start with only a few subjects in phase 1, tens of people, then you go to a few dozen or a couple of hundred people max, and then you do a phase 3 trial, which is thousands of people. And then there's usually a gap between each of these things. But even before that, you do animal studies, all animal studies, not just the ones that are essential before going to humans, but all sorts of animal studies, and then you make a decision, and between each phase, there's a gap to think about it, companies to make decisions, both business and logistical, and so on and so forth. And then you do manufacturing after there's approval. In this case, this is the outbreak paradigm, which was developed in the intervening years between the Ebola outbreak in West Africa and this outbreak. And so this gap is very substantial. This gap between those outbreaks has actually been a blessing in disguise, because yes, it was a tragic incident, the West African Ebola outbreak, but those who pay attention to this for a living and leaders in vaccinology, it was a wake-up call for them, because even when the technology was there, it took a lot more time it took a lot of time to develop a viable vaccine against the Ebola virus, during that period between, for the Ebola outbreak. And so therefore it was realized that we developed this paradigm, and which was followed, that you identify the target on the virus earlier on, and then identify a partner. So a company with the research institute, for example, NIH partnered with Moderna, BioNTech, a small biotech company, relatively small biotech research company, partnered with Pfizer, and so on and so forth. And Oxford in one of the international vaccines, partnered with AstraZeneca, and Harvard partnered with Johnson and Johnson. So those partnerships existed, but very quickly the identification of the target happened, and then you went to a large manufacturer to sort of manufacture doses for a trial. Then first in human trials were merged. Phase 1, 2, 3 were merged. It's not that you didn't do phase 1, 2, 3 level data, but you had a rolling enrollment and a very intensive independent safety monitoring process so that you monitor it on an ongoing basis. And then at the same time, manufacturing happened in parallel. I think we could have scaled up even more, but the fact that there was a lot of investment in manufacturing even before each of these products were licensed was very was a very solid, I think, investment that paid off. Look, in the future, I think we could do it even better, but it could have been much worse in terms of delays, etc. So just a little bit of virology. I'm not going to overwhelm you with a lot of technical details, but I'll just say that there are different kinds of vaccines that started out. But the big thing is that most of them, 80–90% of them, target one protein on the virus. So this is the coronavirus, and it has this feature. It's called the coronavirus. I don't know what happened. It's called the coronavirus because it has this crown shape, structure outside, at the periphery, and you look at it when you look at it under an electron microscope, it looks like a crown. And I think, my theory is it could have been something else if an American or a Japanese or a French scientist would have identified it, but it was, since it was identified by a British woman first time under an electron microscope. I'm talking about any coronavirus from any, not this specific type of virus, but the coronavirus family. The first coronavirus was identified by a British woman. So I guess her mind went to the crown when she looked at it under the microscope, the electron microscope. So then it's these spike proteins that are of interest, but there are other proteins as well. There are these envelope proteins that keep the viral envelope intact. There's matrix protein that provides stability to that envelope. And then you have the nucleoprotein that contains the virus's own RNA. So the focus is on this spike protein, and there are different kinds of vaccines that have, that target that spike protein. And I'll go into the details for two of those that are the most important, two types of vaccines. The first one is mRNA vaccine, or a messenger RNA vaccine. So the idea is that under normal circumstances, you have a cell where your own genetic material produces a DNA, your own DNA sends a message to this peripheral machinery that produces proteins through a messenger RNA, which is not shown here, but it comes from the cell. You send a messenger RNA from your DNA. So it's translated, and then this transcription, it's transcribed into messenger RNA from your cell, and then this translation of that messenger RNA happens in your cytosol, meaning outside the nucleus, where your own genetic material is not present, or your own DNA is not present. What these vaccines do is that they package an external. They bypass that process of your own DNA sending a message to your protein manufacturing factories in your cells. What it does is that it takes the messenger RNA, encapsulates it in a lipid nanoparticle, so just tiny lipid particle, fat type particle, so that it's stable. It can go to the cell. It goes there, and then this messenger RNA communicates with the protein manufacturing mechanism of your cell. And it creates these proteins, these spike proteins from your own cell. So the reason I'm going into this much detail is that it bypasses the whole process of talking directly to your own DNA, which is in the cell nucleus. So there's a myth out there that has something to do with working through your own genes. No, it doesn't work through your own genes. It works through the protein manufacturing machinery of your cell. And then these are excreted or expressed in the surface of these your own cells, and then they are taken up and seen by the cells of your own immune system, and they mount an immune response. And so that response is pretty robust. But it's like, normal vaccine response is when you see an antigen or a protein from a virus, not you mount a response, but the next time when the real thing happens, you're ready and you mount antibodies and memory cells and all sorts of B and T cells without going into details. And the bottom line is your body is ready to respond to the actual infection. So that's what's happening. And here what you're doing is you're making it prepared through this messenger RNA. The other way of doing it is a viral vector vaccine, which is the JNJ vaccine, is that you take a virus, you take a virus which doesn't cause disease or severe disease in humans. You put the spike protein on top of that virus, so create a chimera kind of thing, or a viral vector. It can replicate or multiply in the body or not multiply. We are learning that that doesn't matter. And the vaccines that have been being used are non-replicating virus, but the idea is that you show this protein to the immune system, and the immune system gets ready for the actual infection by seeing it in the context of another virus. So therefore, you don't get the disease, but your immune system gets ready and sees these spike proteins. So the first one is the Pfizer-BioNTech vaccine, which is an mRNA vaccine. It's shown to be 95% effective against mild any disease which is lab confirmed. And go into the details. It requires 2 doses. Up until recently, the storage requirement was -70, but now it can be stored at -20. -70 is this ultra cold chain, not the normal, but really cold freezer. -20 is like similar to your ice cream fridge in terms of technology, and the ice cream freezer in terms of technology. Now for a couple of weeks it can be stored. FDA has given its new approval. It requires 2 doses. It's been approved in multiple countries. Similarly, Moderna's messenger RNA vaccine has similar efficacy against lab-confirmed COVID-19. And it has 20%. It can be stored at from the outset at -20 degrees Celsius, and it requires 2 doses. There has been a lot of effort to collect safety data. Everyone who gets vaccinated should have access to this vSafe app, and CDC then follows up if there is an event of concern. And what we have found is that these vaccines have a fairly good safety record, but they give you transient symptoms that impact you for a day or 2, and then these symptoms go away. That's a sign that our immune system is getting activated pretty substantially. And when that happens, one thing is that happens is that you get some people get pain, fever, headache, fatigue, etc. But more so is pain, fatigue, and headache are the more frequent ones. They're more after the 2 doses. But it is, I think, these are transient things that go away. I'll talk about a couple of other adverse events. There is a CDC system that monitors events that arise. It's the nation's it's called VAERS, Vaccine Adverse Events Reporting System. It's the nation's early warning system for vaccine safety. And then they looked at anaphylaxis or severe allergic reaction, their type of severe allergic reactions. And what they found was that these rates were fairly low. And I'll look at this. Actually, this is a more up-to-date slide that shows that according to their estimate, it's the anaphylactic reaction is 3 per million doses for the Moderna vaccine and 5 per million doses for Pfizer-BioNTech vaccine in early estimates. But in those estimates, which is better than even what was reported in early estimates, because Pfizer was around 11 per million doses administered. So this is good news. There are newer estimates that will update this, but more or less the bottom line is that these are while anaphylactic reactions, these really severe allergic reactions occur. They occur in people, mostly with people with previous history of anaphylactic reactions or severe allergies to any of the components in vaccines, and there's a screening process for that. But even more importantly, that in addition to being rare, it's part of the standard protocol for vaccine sites in the US to be able to take care of these reactions. And the fact that you have to wait from 15 to 30 minutes based on your history, and 15 minutes for everyone, is because of that they monitor you, because that's when they start happening, these reactions, and then they can follow up and address that. So we have been able to manage even these rare events. We have been able to manage these events fairly effectively. There's the newest one is the Janssen or JNJ vaccine. That's a viral vector vaccine. Its efficacy in the US was 72% against lab-confirmed moderate to severe disease. And it can be stored in fridge, and so that means it can be deployed more easily and more quickly and more peripherally, and it requires one dose. So that's a great asset. But this is a summary in terms of how these different vaccines compare. The Pfizer, Moderna, and J&J, the number of doses are two each for the mRNA vaccines, the Pfizer and Moderna, and for Janssen, it's one dose. The efficacy rates that I showed you, they are different for mild to moderate disease, but the good news is, so this is important to remember, that when it comes to hospitalization and really severe diseases, specifically hospitalization and death, all three of them are approximately 100% effective. So that's important to remember. So if you're, with one infection, the J&J vaccine may have slightly lower efficacy against, all disease, mild form of disease, and even moderate one. And moderate definition is very liberal definition, doesn't include hospitalization. But when it comes to severe disease, your ability to to stay away from severe disease and specifically death, these vaccines are equal or equivalent. The other thing is the initial phase of the rollout of this vaccine was pretty slow, but then it has picked up. So last night, it was 4.9 million doses were administered, but it was a reporting issue. But we are averaging approximately 2.3 to 2.5 million doses a day in this country. We started slowly. There were several reasons for that. The country, the Operation Warp Speed did a really good job of developing vaccines, but they built a really fancy plane and forgot to build a runway to land it. I think both statements are fair, that it was a good effort for developing a vaccine, but not really an optimal or a reasonable effort for deploying them. But the other part is that in early phases of any public health program, there are a few hiccups. So the initial part was patchy, but since late January, things picked up pretty substantially, and they continue to go up. And the target that was mentioned by the president of July 4th being, us being able to gather in small groups. I still don't think it would be an idea to have these huge parties, but a small group, a small family group, or a small group of vaccinated friends, I think that's an achievable goal, and things will get better from there. But there are a few threats to this success. So there are variants emerging from these viruses across the across the US and throughout the world. The first one is the B.1.1.7 variant, which was which is a variant from that was initially identified in the UK. B.1.3.5.1 variant that was initially identified in South Africa, and P.1 variant that was initially identified in Brazil. There are a few other variants of concerns that were initially identified in the US. But the bottom line is that all three of them seem to transmit more efficiently. So that means they are more infectious than the baseline variant of the virus. So that's concerning. There is mixed evidence whether they are more lethal or cause more disease, slightly more lethal, etc. But even if they're causing more infection, they have the potential of increasing total number of deaths. Having said that, in the next few months, there are a few things going against us and that should concern us. One is the spread of variants. But there are a few things that are going in our favor. First of all, our current vaccines work very effectively, very reasonably against B.1.1.7. The evidence is mixed against the other two variants for moderate disease, but for severe disease, they have a reasonable, even though not perfect, efficacy against these two variants as well. The other thing that's going in our favor is the fact that the weather is warming up, more and more people are getting vaccinated, and more high-risk people are getting vaccinated. So that's going in our favor. On the other hand, some states are opening things too quickly. Nobody is in favor of a full-on lockdown at this point. But in terms of restaurant capacity, lifting mask mandates, and so on and so forth, that exposes us to risk through these variants. But these variants also highlight the fact that none of us are safe unless everyone is safe. And so we're not, so therefore the US needs to invest in increasing vaccine capacity and distribution throughout the world so that these variants do not come back and threaten us. And besides, that's the most, the richest country in the world has a moral responsibility to look out for others as well. But on top of that, it's in our self-interest to ensure that there is vaccination. The vaccines are widely deployed. I'll skip this one in the interest of time. One of the things some of us have been proposing is that CDC should have, but they have now issued some guidelines, but they should have perhaps done that 2-3 weeks ago because the evidence was there, is to have how vaccinated individuals can interact safely. So now the CDC guidance says, and appropriately so, that vaccinated individuals can have small gatherings indoors without masks. No need to isolate or get tested if around someone who has COVID-19 unless they have symptoms. They should wear masks in public and workplace, and maintain social distance in public and workplace, and avoid medium and large gatherings, and can have even interact with low risk individuals who are not vaccinated. So for example, grandparents can hug their grandchildren, and that's a big deal. From a public health perspective as well, isolation and is one of the is a risk factor, and so the idea is that slowly we should move towards more open interaction. As more and more people get vaccinated, we'll be able to do that. Just to tell you a little bit about some of my other work. I had the privilege of being part of the National Academies of Science, Engineering, and Medicine to come up with the first allocation framework. So the idea wasn't to create a state level framework, but we were commissioned by the directors of NIH and the director of CDC to come up with an overall framework and overall strategy that then can inform CDC's approach and the state's approach. And the big thing that we put our weight on was the fact that we said that we should have, in a pandemic where there is limited amount of vaccine, we could have two strategies. One is to interrupt transmission or by vaccinating indiscriminately, but higher number, and then eventually waiting for the numbers to get to a certain level, or we could have a mortality first approach. And we decided, and we had scientists and bioethicists in the group, and we decided to put emphasis on a mortality-based approach, not a transmission interruption-based approach. And here's the reason why. Look, there are many valid claims to being prioritized for vaccination, but none of, but there are other claims. You can give a stimulus to at least partially overturn the impacts of an economic blow that a population takes. You can have a summer semester, or you can try to reverse some of the learning losses, etc., although not completely. But the most irreversible of these outcomes is death. You can bring back people to life. And so therefore, death is irreversible. That's why mortality-based, mortality-first approach makes sense. There's a social consensus on that, but also if you wanted to interrupt transmission, you would need a critical mass of people to be vaccinated, and during that time, a lot of high-risk people will die. Initially, the trials were not designed to assess impact on transmission of the virus. It was only for your own protection. Now there's evidence, but when these things were being developed, And then there is limited transmission data on risk groups, etc. So we came up with this framework, which was translated broadly. That gave the terminology of phase 1A, phase 1B was developed. In that, the phases were a lot smaller than what Connecticut and other states have done. But more or less, the idea was to target just the high-risk healthcare workers, first responders, people with significantly higher risk of comorbidity. Not everyone with any comorbidity, but significantly higher risk of comorbidity, meaning more than 2 or more comorbidities. These people are not missed by the health system. And then older adults living in long-term care facilities. So that was the phase 1, much smaller. Then quickly go to all of these groups: teachers, critical workers, all people of all ages with comorbid conditions, people in homeless shelters, prisons, and all older adults. So that was the overall approach. And then the idea is to focus on areas where there's higher social vulnerability based on income, race, age. So don't use one variables, but an index of all variables to identify these areas of social vulnerability. Then we amended this with a few colleagues at Johns Hopkins. We said that the initial cutoff states was 75 plus. We said, no, that's an inequitable cutoff, but adults over 80, so we've said that 75% cutoff meant that only 44% of Black deaths were captured. We're not showing it here, but more than 70% of white deaths were captured if the cutoff was at 75. At 65, you begin to even out that number. And so it was very reasonable to take an age-based approach up to 60 or even 55. But what some states did was then they switched to overall age-based approach, which is not supported as much by evidence as these based approaches, because at younger ages, it's the comorbidity, especially multiple comorbidity, that becomes more important. I'll skip here, the last slide, and in the interest of time, and would be happy to take questions.
Great, thank you so much. We actually have a question from the audience, and if anybody wants to raise their hand and give it orally or put it in the chat, that's fine. So the question is—
I've got a couple.
Okay, great. In one moment, please.
Sure.
The first question: isn't one of the dangers of not working quickly to slow down transmission that more variants might arise?
No, absolutely, that's a risk. But that means that you increase overall supply. But if your decision is what's the best use of the next dose, then it's still, because you need a critical mass to have any impact on reduction of the probability of transmission. But within that group, you focus on those who are at highest risk of dying when the limited doses are there, because you need that critical mass. So the solution for that is that you move up the overall timeline, but within that timeline, it still makes sense to go with the mortality first approach.
And there's a sort of a corollary question. When you modeled the two approaches, did you look at mortality in the near term, or did you look at mortality, say, 3 years after this whole thing hopefully will be gone?
Yeah. So we looked at, so there were several models. So Avera had, we worked with the World Health Organization's committee that makes these decisions and allocate, these recommendations for the world. We did, once we developed that strategy, it was a similar strategy for the World Health Organization that I didn't show, but it was a mortality first strategy. And other countries have actually implemented it even with more fidelity, with a more targeted focus on mortality. But the idea was to actually, so it was then evaluated in different models. It wasn't much of a difference in terms of the relative distribution. It was whether we were looking at deaths now or later, although the initial thinking was based on deaths, direct deaths from COVID-19.
Great, thank you. That's very interesting. Mr. Racke, would you like to ask your question, please?
Yes, if I may. I've been watching the daily and the weekly moving average infection rates published by the CDC. And after the New Year's holiday, they were dropping extremely fast. And they continued to drop for about 2 months. And all of a sudden, they seem to have leveled off, and leveled off more than just a blip in the statistical sampling. So I got really two questions. Why were they dropping gradually rather than suddenly after the January holidays? And why have they suddenly leveled off?
So there is some initial data, and it's not confirmed about the leveling off, but we do know that there are a few things that are happening. First of all, there was a bump during the holidays, and that went down. The other thing we documented fairly convincingly in the early part of the outbreak, throughout using cell phone data, anonymized cell phone data in the US. So meaning very reliable data, actually looking at people's movements, not at the individual level, but at the group level, since it was anonymized. We found that in the early part of the outbreak, people, even before the shelter in place or stay at home orders, people modified their behavior when there was more death and when there was more disease. People in the local, in rural communities or non-urban areas were more attentive to local mortality and case trends. People in larger areas were more attuned to the national trends, which makes more sense because sort of you could argue that LA is more synchronous with New York than sort of some of the rural counties in California, for example. And so those kinds of things, the voluntary behavior was there. The policy interventions like shelter in place or lockdown orders did have an impact, but it was it wasn't that all of the reduction was due to just that lockdown. It did add to that effect, but there was a strong voluntary effect as well. So extending that work, now we are looking at the trend and how people moved around in this period as well. What we are seeing is, so we have another national survey that said that there was an uptick since November as cases went up on not just stay-at-home behavior, but their people's own preventive behavior. So when there was a lot of stuff going on, it didn't go back to the early phases, but people did modify their behavior. And so it was partially that, partially the fact that the big surge of travel, that's impact made it through the system. And now the reason why it seems to have leveled off is that these behaviors have seemed to have leveled off a little bit, but also in certain places we are seeing these variants of concern emerging. So in Connecticut, we know that the UK variant, which is more transmissible, is replacing our current, the run-of-the-mill variant of the virus fairly quickly. And by the end of March, that will be the predominant variant throughout the US, including Connecticut. And so that's what's happening. So a more infectious strain has come, and it sits on, on a bed of some good things happening. Our best hope is that even if and sorry, before I get to that, this is precisely why the CDC has been emphasizing that, look, you can do some activities, but this is not, we can't afford to let our guard down at this point because these rates can even come back up. Our best hope is that people will have at least some baseline preventive behavior for the next few months. And the vaccines, vaccinating high-risk groups quickly would mean that there is a decoupling between cases and deaths. Etc. And so that's what we are hanging our hats on. And then with the warming weather, people will go outside more, open their windows more, all of these risk factors. Look, the virus doesn't go away in the summer, especially in the first 2-3 years. No, pandemic viruses find so many hosts that they don't vanish, like some of the other respiratory viruses. That will start happening 2-3 years from now when a lot of people are immune. But their efficiency of transfer does go down as the weather warms up. So all of these things dictate the dynamics of the virus.
So we have a question about the variants, and that is there a way that those who have contracted COVID can be identified as having a variant and be told they have it? Are people with variants being identified and tracked?
That's a really good question. So look, there are a lot of things we are good at, but one of the things we, as a country, but one of the things we suffered from was a lack of investment and actually reduction in investment in our public health infrastructure, including our state level lab infrastructure that used to be supported by federal dollars and was the envy of the world. And one of the things that happened was that we were left behind in genomic sequencing of viruses or all pathogens. The Brits do it really, really, really well. The Danes do it, and a lot of other countries in Europe do it really well. So we have gaps in our genomic surveillance. And now, since we are ramping up that capacity, it's being ramped up mostly in research labs. And research labs are not legally allowed to give individual patient results. And so that's the problem there. They have to be what's called CLIA certified lab. And there, since those labs take time to scale up for individual patient diagnosis, most of the patients don't have, and their physicians don't have that data to give to individual patients. What is happening is at an aggregate level, these samples are being analyzed and we know that what's happening in the community. So that variant information comes from that next step of sequencing, not just a simple PCR.
So if you had a group of 10 people and 5 of them had recovered from COVID infection, the real disease, and 5 of them had received a vaccination, is there any difference between them? Are there biomarkers, or is there a difference between them to susceptibility to further infection?
We don't know that yet. There are a few things. So that's why it's a new virus. So that's why it's an active area of research, and my group is partially looking at that. We do know there's emerging evidence that going forward, and this is not a recommendation yet. So right now the recommendation is those who have had infection should take both doses if it is warranted. But there may be a recommendation as the evidence builds that they may need only 1 dose. So that we know. But it's unlikely that we will ever be in a situation where we'll be able to say that even if you were infected before, do not get vaccinated. Here's the reason why: because the variants are emerging, and we at least for the next couple of years, as we understand this virus, we don't know, because the uniform an infection is not a standardized dose of the natural infection is not a standardized dose of a virus. A vaccine is. So your infection may be different than my infection, etc. So therefore, it is. I think if we go to a situation where there is a consideration of the previous immune status due to infection, there's still one of the recommendations is both at the WHO level and at the CDC level is that you can wait, you can afford to wait. If you have already had an infection, you can wait for at least 3 months and then vaccinate, start your vaccine. So that we know that there's reasonable protection. What happens beyond that, we don't know at this point, because not enough time has passed for us to have a long-term follow-up.
We had a couple of questions about children. One was, would you explain how the trials on children are going? And are there even more care being taken to follow up on children's reactions? And then the other question was, when will children be vaccinated?
That's a really good question. So look, for herd immunity, we need everyone, including children. So everyone counts. And we know children don't get severe disease at the same rate as older individuals, but they do get it. So everyone is at risk, including children, but the relative risk is lower. We also know that children transmit the virus, even if they don't get sick, etc. So for both of these reasons, we need to vaccinate children. So the first thing is the Pfizer vaccine is recommended through 16 years of age, or is authorized for 16 years of age already. And so when the turn comes, there is an option for children 16 and above to get vaccinated. The other trials are ongoing. Some have started, the others will start enrolling soon. And the timeline is around summer when the results will come out of children. So it will be that as the rest of the adult population gets vaccinated, we still have that capacity, meaning sort of FEMA is still out there. Large medical centers like Yale still is maintaining its capacity to vaccinate at high numbers. For example, at Yale, the big bottleneck is the supply and not the, and that's true for Harvard Healthcare, et cetera, without knowing the details, but that's what seems to be the case in a lot of places, that the bottleneck is the supply. The capacity to deliver has been increased. So that means that capacity will be there. And as adult vaccination tapers off, if you have a childhood recommendation that we hope to be able to vaccinate children fairly quickly. One of the concerns I have is the interim period. There will be a lot of families where both parents are vaccinated, even an older sibling is vaccinated or something, or if it's a multi-generational family, a grandparent is also vaccinated, but the children are not. And as recommendations come out for more and more safe activities for those who are vaccinated, we need to take care of the mental health of our teens specifically, and others whose social lives have been severely disrupted in that interim period of 3-4 months, when we are evaluating these vaccines for younger individuals, for children and teens under 16, and during that period, before they can get vaccinated, and now that their own parents and grandparents are vaccinated. So that's another place where I think we need an urgent public health intervention.
You mentioned that communities of color are especially impacted by COVID, but my understanding is that they've also been especially resistant to vaccination. And although Republican men and communities of color are not often spoken about in the same sentence, that's another subpopulation that is distrustful or not accepting. Can you say a word about why people don't accept the vaccination, and especially what can be done to bring them into the tent?
So there are two things. There's a good news and there's a not so good news. So the acceptance have ticked up in communities of color, especially Black communities. Less so in a couple of other communities of color, in Latinx communities and Native American communities, but that has also ticked up. And that hasn't happened automatically. There's been a huge effort, both by the federal government, state governments, irrespective of, by the way, there's a lot of noise in terms of politics, et cetera. There are some less than wise decisions based on politics, but there are health departments like Tennessee, and local health departments in Texas that are doing a pretty decent job of reaching out to communities of color, not just in Connecticut. Connecticut is doing that as well. So just to provide some context, that there is an effort, but also effort from leadership. Historically, Black colleges and universities have made an effort. African American physician organizations, for example, have made an effort to do that. So those efforts have started to pay off, and it wasn't all irrational. Look, this is not the group. So there's a very small 2-3% of the group that will never get vaccinated. Even if you put mom and apple pie in a shot, they will refuse vaccines. This is not the group we are talking about. There was a much larger group of people who were wait and see, who had trust issues, and a lot of them warranted. So frankly, our healthcare system is not equitable. It doesn't diagnose people equitably in terms of their comorbid conditions. It doesn't have, and it's been shown, it's not a political statement, it's been empirically shown. And so that was part of the suspicion. But these efforts have paid off. The other group, which is now right-leaning men, that gap hasn't closed. And so that's the next effort. In my group, so I didn't present those data in the interest of time. We have been doing studies to how to communicate around vaccines with various groups, and we have done that. And we have, briefly speaking, for that kind of a group, especially amongst males, a liberty-based messaging. So emphasizing liberty in your messaging, speaking to their value of liberty, is a potent, or at least partially potent, intervention. And it would have helped, frankly, it would have helped. We actually showed that in a trial if President Trump would have come out in favor of vaccination. President Bush came out in favor of vaccination with the other former presidents, but I think President Trump should have come out, and the former First Lady should have come out, should have taken the vaccine. And it's okay for them to take the credit as well. They're, at the end of the day, former politicians, and you can have that public discussion. But I think it serves their own interest and the country's interest if they would have taken the vaccine on TV, and even now if they come out and record a PSA, that would be a very potent PSA. And I'm not just saying that based on conjecture. We actually did a trial where we gave that kind of a situation scenario back in September to people. And it turns out it would have moved people, especially right-leaning individuals.
So someone asked the question, could you comment on the reactions of concern to the AstraZeneca vaccine? And I might add, are there any prospects for approval in the United States?
Yeah, so there is a trial going on in the US that they will present. So the US FDA said that they're not going to accept, it's not a blanket thing. The US FDA accepts international trials all the time. But for AstraZeneca, some of the initial trials were smaller than what FDA would have wanted and were more variable, did not have a uniform protocol, et cetera, and all of the stuff and standardized dosing. So FDA said, no, they were always planning to do a US trial. The FDA said, we're going to wait for the US data to come out. So we're hoping for those data to come out in the next few weeks. Meaning 6 to 8 weeks is my best guess, to be announced. And then there's a little bit of a gap after that when they apply for authorization. This is the vaccine that will be used by the WHO most because they had an early licensing agreement with the Serum Institute of India, which is the biggest producer of vaccines in the world by volume. And so that's why, WHO and other entities now with US support, so the administration has said we're going to give $2 billion now and $2 billion later for that effort. EU had already committed a lot of money for that, and some countries are self-paying, et cetera. But that would be the primary vaccine there. So I think you're talking about some of the thromboembolic events that came out, in the press. Right now, the evidence is not that it's a causal relationship. We've looked at data, WHO has looked at data around this, that it doesn't suggest a causal relationship. Countries that have other options have made the decision to pause vaccination. They haven't withdrawn, nobody has withdrawn as they evaluate the data. Most countries where this vaccine is being used, they have decided not to pause vaccination. So it's the, man bite dog or dog bite man story. The ones that pause the vaccination make it to the news. The countries that don't pause vaccination, and that includes a lot of European countries as well. So it's not just a low-income country vaccine. A lot of Europe is using this as well. Most countries that are using it haven't paused vaccination around this vaccine, but they're evaluating it. Doesn't seem to be causally associated.
And is that a viral vector similar to J&J?
Yeah, so that's an even more, it's an interesting vector. It's called a ChAdOx. So the CH in ChAdOx stands for chimpanzee. It's a chimpanzee adenovirus Oxford vaccine. So what they do is they do not take the virus as the vector that causes disease in humans. They took a virus, adenovirus, which is the type of virus that is in the J&J vaccine as well. But the version of it they took was the one that caused disease in chimpanzees, not humans. So they adapted that and put a spike protein on that.
Okay. Let's see. So to reiterate on the current recommendations that people should be wearing masks in public, how long will that recommendation be in effect, do you think?
I think we will have, I think the mask one should be, from an evidence perspective, should be one of the last recommendations to go away. Frankly, setting politics aside, that's the least intrusive intervention, to be very honest. unless there's a few other, except for a very, very few specific cases, like during teaching where teachers need to communicate, etc., and a few things. I think it will be like a dimmer switch, and the lights have started to come up even now. I think slowly we will go towards smaller gatherings, outdoor gatherings, to somewhat larger gatherings. We would go to a select group of people coming back to work, etc., for in-person work. And then we will go for outdoor gathering, like sports events with higher capacity. And then we would go for mask being optional, etc. So that's the trajectory I see. When we get there depends on what the vaccine uptake is and what the variants do to the outbreak. So I don't think variants will wipe out our successes. I think they may dent our success, but they may not. They are unlikely to wipe out our success. They may delay effective control, but they cannot. They are unlikely to sort of eliminate effective control. So I think to answer your question, we're looking at fall when mask becomes optional, but a lot of normal activities will start happening well before that. So while the question was about masks, I just want to make sure people don't take that as an indicator for return of a lot of normal activities.
Are there plans in the works for, say, a booster to deal with the variants?
Yes, and I've been an early proponent of that, and companies and NIH are actually working on booster doses with the same virus, but also what we call heterologous booster doses, meaning with the people who are previously vaccinated, give them a new vaccine with the new variant. For the new variant, etc. So that is all in the works. They're doing parallel studies so that we don't, but the policy decision is still several months away. So there's a difference between having tools in our toolbox and then, making the policy decision of actually using them.
Can you say a word about testing? We haven't heard very much about that since the vaccines have hit the news, either about the viral testing or antibody testing.
Yeah.
Is that still a part of the approach?
Yes. By the way, I have another call in a few minutes, so if that's okay, I'll take this as the last question. It is very much part of the strategy. So PCR testing capacity has been substantially increased, and it is very much part of the strategy. For example, at Yale, we are using testing even before the vaccine. Yale de-densified, reduced the number of students on campus, but unlike a lot of our peers, we stayed open. We had hybrid, including some in-person classes, etc. And the reason why we did that was that higher education was important, and we thought we could do it safely, and testing was part of that core strategy. So similarly, I think for keeping schools open, especially because children are not vaccinated, or in opening them up, testing will be a huge part of that strategy, including home-based antibody testing. So there was a federal large purchase of that. I think we should expand that. I think by fall we had the technology and even the manufacturing capacity, if the federal government wanted, to mail a huge chunk of our population these tests on a weekly or a monthly basis. So I don't think even that would be happening. That would, that level of scaling up of home-based testing will happen even now, even under this administration. But I think because their focus is on vaccination, etc. But I think they are making some of these tests available, especially through school systems, school districts, etc. So sorry, I need to wrap up for the next call.
Thank you so much. We really appreciate it, and take care. Thank you, everyone, for coming.